Good day. We're going to be doing several presentations on adolescent medicine. The Chiefs and I work together on 4 topics. The first is going to be screening for mental health in adolescents. And Dr. Sherelle Coates, our senior fellow, and I worked on this presentation together. So if you take a look at the YRBS, which is the Youth Risk Behavior Survey for 2017, in the survey you'll notice that there's several questions that ask about depression. The one that I'm using here in this presentation to look at sort of the prevalence is that the person filling out the form said, "I was so sad or hopeless for 2 or more consecutive weeks in this past year that I stopped doing some usual activities." This is endorsed by nearly 1/3 of the people taking the survey, 41% females and 21% males, which is very consistent with the 2-to-1 ratio that we expect between young men and young women and young men, sorry. And then the more serious part of it is that they not only considered suicide, but that they seriously considered it. 17% endorsed this, and again, about a 2-to-1 ratio, 22% of the young women and 12% of the males. Of note, 1 out of 7 of the adolescents who completed the survey reported that they had made a plan. So clearly there's a need for screening the adolescent in the primary care setting for depression and for suicide. And the American Academy of Pediatrics recommends that pediatricians screen and, if appropriate, begin treatment for depression in the primary care setting. And as you've all rotated through teen health, you can see that we do it, but we also encourage the residents to do it and to continue doing it if they go into primary care later on. There's several different screening instruments that are available. We use the PHQ-2 as the screen, and those 2 questions are, over the past 2 weeks, how often have you been bothered by any of the following problems? And the 2 questions are little interest or pleasure in doing things on a 4-point Likert type scale from not at all to several days, to more than half the days, to nearly every day. And the second question is, over the past 2 weeks, how often have you been bothered by feeling down, depressed, or hopeless? And again, the same Likert type scale, from not at all to nearly every day. If the score is 3 or greater, then we administer the PHQ-9. There are other instruments that are available, including, for example, the Beck Depression Inventory, and the Child Behavioral Inventory, but we like using the PHQ-9 because it helps us both establish a diagnosis and monitor therapy. And what I have here is a copy of the PHQ-9. You can actually look it up on the web, and there are several different sites that you can download this from. And you can see that the 9 questions range from little interest or pleasure in doing things to thoughts that we'd be better off dead or hurting yourself. So after we do the PHQ-2 and the score is 3 or greater, then we administer the PHQ-9. We have them fill it out, and you need to take special interest in what the response is to number 9 and follow that through with some other questions. And then you can do the score. The scoring is, for example, if they say more than half the days for poor appetite or overeating, that gives them 2 points. You total up the points on the scale. It goes from 0 to 27, and then you use this as a general guideline. The last question you might have noted after question 9 is sort of an issue of how much this is bothering you. And again, if it's minimal, you just rescreen next year when they're coming in. If they're mild, you would reassess in perhaps the next 3 to 6 months. And at moderate or greater, then you need to sort of consider whether you want to recommend management at that point, or to have them return and reassess in 1 to 2 months. So if the scores are in the moderate range, or there's no improvement in the scores in 6 to 8 weeks, you'd be discussing medication and counseling. If it's persistent mild, you also would be discussing medication and or therapy. The studies show that either modality alone works in perhaps 60 to 65% of the people, but the two modalities together work in over 80% of the people. The medications we would consider, first line would be SSRIs. They're proven to be effective and safe, and typically we would start again with the ones that we have listed: fluoxetine, sertraline, or escitalopram. Therapy is at least as effective as medication alone. There's a couple of studies that suggest that therapy might be a little bit more effective. Recent functional MRI studies demonstrate that medication helps certain areas of the brain which are either up or down regulated, whereas psychotherapy works in other parts of the brain. And the reason that working both together is better than either alone is that you then optimize your opportunity for hitting different areas of the brain using two together. Okay, so evaluation of anxiety. So when we're doing our annual physicals, or if parents come in with specific issues with their adolescent, then we would do the GAD-7. So if there's a family history of anxiety, or the family describes the adolescent patient, or they describe themselves as a worrier, or they have difficulty relaxing, or they're very irritable. Now, irritability can be a sign of anxiety, can be a sign of depression, and can be a sign of bipolar. So it's not like irritability says, oh my gosh, this is somebody who has anxiety. So we use the GAD-7, and again, it's an instrument that can be downloaded from the internet, and the scores go from minimal to severe. And again, although the prevalence of depression is quite high, and we suggested that, among males for depression it's about 20%, and for females it's about 40%. For anxiety, the overall prevalence is about 8%. So it's much less prevalent, but you still should be thinking about it. And I could have, in fact, I might have almost copied the medication or counseling aspects. So again, if it's persistent mild range, or if there's a moderate level, you should discuss with the patient and with the family about starting therapy or considering medication. And again, the SSRIs are our treatment of choice for medication. They're effective, they're safe, and we'd be starting with the same three agents: fluoxetine, sertraline, or escitalopram. Sorry. If they're having panic attacks, or if their episodes are prolonged, you can consider doing abortive therapy with hydroxyzine. Hydroxyzine used to be used as an antihistamine. They discontinued, or they actually modified it as some of the current therapies because they were looking for medications that had less central nervous system side effects. It so happens that those central nervous system side effects include not only sedating but also relieving anxiety. And so we use hydroxyzine in patients to try to break an attack. My personal belief is that I avoid benzos as much as possible because they're both habit forming and there's a high abuse potential, especially with people with anxiety. They begin to start taking the benzos in order to prevent the feelings like they're going to get an attack. And it rapidly devolves into a very difficult situation. For this section, I would recommend further reading from this paper in Pediatrics. It discusses in great detail about screening, the importance of the primary care provider in the care for depression and anxiety in adolescents, and also with initial management approaches. Thank you so much.